Okay, good evening, everyone. I welcome you all to our second session for inguinal hernia, which is a video masterclass. So before we start, I would like to invite everyone to download the Elsa app, and then we have a special rate, membership rate for July, which is just 150 USD. Previously it was 200. So please join us by downloading the app. And also when you log into the Elsa website, you can now see an e-learning portal where you can actually follow some of our courses as well as a virtual reality surgical videos. So you can see how the OT setup and all that. So please do log into the Elsa website and please also download the Elsa app. And I welcome all you to the Elsa, all of you to the Elsa family. Yeah. Next slide. So I think just some ground rules. So all panelists and speakers, please keep the microphone mute when you're not talking. All participants are encouraged to ask questions through the Q&A. And the MCQ today, you can actually have more time, and we will put it up soon after we start the sessions. And then the webinar will be recorded. And then if you want to go back and access the videos, you can actually access through Elsa YouTube channel. You can also go back and see our previous sessions already recorded in the Elsa YouTube channel. And this is broadcasted over Facebook. So I think without any delay, we can move on to today's session. Prof, next slide. So I welcome all of our speakers here. Dr. Sajid Malik will be talking to you about TEP. Sajid is from Pakistan. He's an MIS surgeon. Dr. Hiroshi Hirokawa, he'll be talking to us about TAPP in Japan. Dr. Hiroshi is a well-known MIS surgeon also from Japan. And Dr. George Yang, who is from Hong Kong, and he'll be talking to us about lap hernia, the role in emergency. Yeah, so I'm so sure whoever knows George has seen his videos, very interesting videos about emergency hernia repair using the endolaparoscopic technique. I'll be talking to you about endolaparoscopic repair for large inguinal hernia or inguinal hernia. And Prof. Lomanto will be talking to you about recurrent hernia today. And Prof, can you go back to the last slide again? Yeah, and Dr. Rajesh Kula will be talking to you about managing complications in endolaparoscopic hernia repair. Dr. Rajesh Kula is from New Delhi, India. Yeah, so now let's move on to one of the videos from our sponsors. So please watch the video. After that, we will start with Dr. Sajid. And I'll pass over the microphone to Mackie. Mackie is actually going to coordinate this course together with me and Prof. So Mackie, after the video, maybe you can continue. Yeah.
Yeah.
Okay.
Right. containing potentially hazardous substances is generated during electrosurgical cutting and coagulation of tissue, also in cases of laser and ultrasound applications. The IES-3 smoke evacuation system is our solution for a safe and clean working environment. The IES-3 filters smoke and odors and extracts aerosol-charged air during open surgical and laparoscopic procedures. For use in the operating room, integrate the IES-3 into a VIA workstation, or use it as a standalone unit. The IES-3 is the universally suitable smoke evacuation system for hospital operating rooms, outpatient facilities, and medical practices. In combination with smoke evacuation pencils, you can cut and coagulate while simultaneously evacuating the resulting smoke. The 5-stage high-efficiency filter removes virtually all particles with diameters of 0.1 micrometers and more. Thus, this filter offers the best possible degree of safety.
So what you saw just now is actually quite timely because we are still in the era of COVID. We are not out of the woods yet. So most of us are waiting for the third wave. So the smoke evacuator is quite handy. We are using it in Singapore, the IES-3. And also the other equipment that you saw is a bipolar energy device, which is reusable. So without any further delay, so I invite Dr. Mackie Filona, who is from Philippines, a well-known MIS surgeon, to start the session. Yeah, Mackie, over to you.
So, thank you, Sujit. So may we give the floor to Sajid. You're the first to present, if I'm not mistaken.
Thank you, Mackie. Thank you, Dr. Sujit. Can you hear me now?
Yes.
Okay. Well, thank you for a brief introduction and giving this opportunity to present this TEP repair for Elsa OP for hybrid inguinal hernia repair. I had this opportunity to learn actually TEP repair with Professor Lumanto and Dr. Sujit, and I always acknowledge them to for this MIS training as well. And well, going into the without delay, I will start my presentation. And before going into the detailed discussion of the TEP repair, I must say that a key to the good repair is actually a critical view of myopectineal orifice. A very good paper by the George published in 2017 about actually what are the different key steps and how to achieve this critical view of myopectineal orifice. And I would advise all the participants to go through this paper, which is very nicely describing about the critical view of the MP orifice. The first step in TEP repair is the pre-operative preparation. Apart from the antibiotic prophylaxis, urinary decompression is very important because you are working in an extraperitoneal space, and it would be very critical for you once the urinary bladder is distended and you are working into the same space. So it's better to ask your patient, as I used to do, is to ask your patient before going into the theater to pass urine and make sure that the bladder is empty. The role of Foley's catheterization is questionable and only reserved for recurrent hernias, bilateral large inguinal hernias, where you are anticipating that the time would be a little bit higher than the usual time. Then you can consider the Foley's catheterization, but you can remove the catheter before the end of the procedure. Equipment is very important for TEP or TAP both repairs. The first thing is the using the Hassan's port for your camera, because it's very critical if you use a simple port, an port, and for a 10 millimeter for your incision into the to go into the extraperitoneal space, it's very important because the second and the third port would be very close to it, and you have to manage the distance between the ports. So it's very critical to use this Hessen's port, which will be by this way you will be able to adjust the port length into the extraperitoneal space. Then the two working ports, 5 mm for your midline incisions and two blunt dissectors. Intestinal, can be used because for inguinal and sometime if there is a peritoneal tear, then would be useful. Scissor, especially the curved one and the insulated one, is very important because when you will do your dissection, I will show you later in my videos that you will be required, and the mesh undertaking device. The first step is the patient position. Arm need to be tucked to the side. You can have then abducted arms as well, but would be very difficult for you and your assistant to stand, because when you are working into the contralateral side, it would be okay. But when you are doing on the ipsilateral side for some dissection, would be difficult for you if the arms are abducted. Patient need to be 10 to 15-degree Trendelenburg position. Hernia side tilted up. It means that if you're working onto the right hernia, if you can see into this picture, if you are working onto the right side of the hernia and standing onto the contralateral side, this right side of the hernia, this side, need to be a little higher. And surgeon, as I told, need to be on the contralateral side, and there is no role of NGT. I will go to 10 steps to follow. All of you must be doing TEP repair, but these are the basic steps which need to be followed for the any TEP repair. The first thing is the camera port access to the TEP space, which is very critical, I believe, because once you are in the wrong plane, then it would be very difficult for you to come back again, and then once the disaster has already been done. If it is a right side hernia, you can give your small incision into the infraumbilical incision like this. For the left side inguinal hernia like this, and for the bilateral, you can go like this. So the first video is like for access to the extraperitoneal space. You give a small incision onto the anterior rectus sheath, expose the rectus abdominis muscle, and once the muscle is exposed, don't cut it. Use your S retractor or pyong to retract the muscle laterally and expose the posterior rectus sheath. Here you can see that my pyong is going below, and then it's over to the posterior rectus sheath. So expose the posterior rectus sheath below to the muscle. There you can enter into, you can place your Hessen's port. Then the second step is doing extraperitoneal space dissection. You can use a blunt dissector or a telescopic. You can use the telescopic dissection approach or a balloon dissection approach. I'm not using balloon. I was trained like this to use a telescopic dissection, which is, I think I have a more advantages. You can critically identify this space of the fascia transversalis between the two layers of the superficial and the deep membrane of the fascia transversalis, and then you can move on, staying into the midline and moving forward and exposing the posterior superior ramus of the pubic symphysis like this. Here you can have a look that the posterior superior ramus is nicely exposed, and you are staying between the two layers of the superficial and the deep layer of the fascia transversalis. Remember that on the top layer, onto the anterior abdominal wall, don't expose the muscle and keep a inferior epigastric vessel on the top while doing dissection. We recommend blunt dissection. You can go with the balloon, but just to share a few disadvantages of like higher cost, longer operative time, asymmetric dissection, and more importantly, it's more traumatic with risk of inferior epigastric vessel injuries. The next step is the placement of your secondary trocars. If I can show you, this is a view of the 10 mm your camera port. So better to place the distal port first. If I can show you in the right side here, So by measuring, you have to stay at least 3 finger breadth above the pubic tubercle. Because if you can go below as well, but it would be very difficult by the end of the procedure for the placement of the mesh. And it's better to stay 3 finger above the pubic symphysis, and the third port need to be placed between the camera port and that the third port. So first you place the 10 mm port, this one, and then you go with the secondary port, suprapubic port, and the lastly into the midway between the camera and the suprapubic port. So the final port position would be like this. So you can have a nice look that your 5 mm port and then the 10 mm port. The next step is the blunt dissection and exposing the Cooper's ligament and starting your lateral dissection. So working into the midline, expose the Cooper's ligament, and I used to go onto the contralateral side as well a little bit to expose the contralateral Cooper's ligament as well, even for the unilateral inguinal hernias. And then you start moving on to the lateral space while staying between the 2 layers of the superficial and to the deep space. And the below you can have a look that you have to keep this fascia onto the deep surface as well, while you have to stay as much high as you can stay, because if you will go down, it will expose the peritoneum and below the arcuate line, and there will be a chances of creating a pneumoperitoneum in the start of the procedure, which could be a complete disaster. And if you will go more higher, it will expose the muscle. So it is very critical to stay between the 2 layers and move laterally and slowly. Initially, I would say it could be a tricky to identify the 2 planes, but later with a learning curve and with experience, you can definitely go with the proper dissection. The next is to identification of the Hasselbeck triangle and identify all spaces. Once you are exposing this triangle, here you can have a look at the small obturator and the femoral hernia in this video. It's a female patient, so it's a round ligament as well, dissecting the round ligament. So apart from this, you will identify the Hasselbeck triangle, identify all the orifices, direct, indirect, and the femoral. You try to reduce the sac, either it's a direct or to the indirect, and you will manage indirect sac accordingly and to the direct sac accordingly. I will show into the next slide. So here for the indirect sac, if it is the indirect, to identify the cord structure and dissection of the sac, you march towards the deep ring slowly, and you have to move in a way. It's all blunt dissection. Don't try to hold these structures with your blunt dissector, because it can injure either the vas or the spermatic vessels. So doing a blunt dissection, this is a rate limiting step, I believe, and move slowly towards the deep ring and expose the lowermost fibers of this peritoneal sac. Identify all the structures again for ligating or incising the cord structures. It is the peritoneum. It is very important to make sure the triangle of Doom structure, the spermatic vessel, and the vas deferens are well behind before ligating it. So you can use, there are different studies onto the ligation after the sac. Either you can use this suture, which I used to, which I was trained in and I'm practicing like this, or you can go with the other techniques as well. Sorry. And then by the end of the procedure, here is the time for the use of this the scissors. So insulated scissor is important because you are working in a very small space, and it can injure to the other structures. So like this, you slowly move on, and then you reduce the incise the sac. After incising of the sac, you prepare the space for the adequate placements of the mesh. You go laterally as high as beyond to the ASIS, not until ASIS rather. You go beyond the ASIS while holding, you're working over the arcuate line. You expose lateral, you do your lateral dissection and prepare a room for the adequate mesh placement. Here you can see I'm trying to expose the psoas muscle laterally. That will be your lateral end of the dissection, and over the triangle of the dome, joining the preperitoneal space with the retroperitoneal space. So that is a space, because if this part of the sac here, if you left it here, this is a one of the reasons for the recurrent indirect inguinal hernias in this patient. So it's very important to do a complete dissections, because I know most of the people, they were like, they place the mesh in that space and using a small size of the mesh, which could be one of the major reasons for the recurrent of these type of the hernias. Well, size of the mesh is it's recommended as 10 into 15. No other question like this to use a smaller mesh for the inguinal hernia repair now. If the defect size is greater than 3 centimeter, yes, this is a very important thing. Before placing the mesh, it's better to go with the TEP plus repair and close the defect. You need to be trained in with that technique. And later for considered closure of the defect, follow with the deployment of the larger mesh if the defect size is more than 3 centimeter. Mesh placement is very tricky. Initially, I was like struggling by the start of my training to even for the placement of the mesh, and it could be very tricky for most of the residents and the young surgeons as well. But the point is to reduce the space, to place it in a way that orient your mesh in a way that the lower edge of the mesh need to be in front of the peritoneum, and you bring the peritoneum or a reduced lipoma over it instead of just placing a mesh. And if I can show you this, not this video, but rather this video. So the placement of the mesh, either you are using an anatomical mesh or a flat sheet. Orientation of the mesh is very important. First, working into the first step need to be working onto the midline, and then orient your mesh over to the pubic symphysis, over to the and then you go below 2 to 3 centimeter below to the pubic symphysis. Then you move on laterally, and the room which you have already prepared for the placement of the mesh. And then you expose the preperitoneal and the retroperitoneal space like this, and then you place the lateralmost edge. Because once your mesh is folded in any of these places, the chances of hernia recurrence would be higher. I used to have either 2 or 3 tags onto the just above the pubic symphysis and not into the bone directly, and then moving on to the top, medial and lateral to the inferior epigastric vessels. You can use a spiral tacking device or to the or a metallic devices as well. But once you are applying, when you are applying these tack, it's ideal to place your arm onto the anterior abdominal wall, because it will give you a nice feeling that you are placing a mesh into, you are placing these tackers not too tightly. Otherwise, it will create a dimpling over to the anterior abdominal wall and would be very painful for the patient as well. The last step would be holding of the mesh while desufflation. And what I used to, I will advise is to hold the mesh onto the right space like this, and then the left edge of the mesh onto the left. This is a bilateral approach, onto the left corner here, and then slowly you desufflate this space and move out, and you will pull out your camera. So the mesh won't be like like a crimpy for the recurrence. The post-op care is a minimum perioperative fluid. Restrict your fluid to 1200 ml, 1000 to 1200 ml is sufficient. Daycare surgery or 23-hour stay depend on the patient condition. Patient can resume its house chores in 3 to 5 days, resume normal light walk in 7 days, avoid weightlifting, carrying strenuous exercises in 30 days. I used to follow up my patients 7 to and 28 days, and usually after 28, the last follow-up in 3 months' time, and I discharge my patients. So in the last, I would say, it's suffice to say that Mr. Sarogleri said, I know more than 100 surgeons whom I would cheerfully allow to remove my gallbladder, but only one to whom I should like to expose my inguinal canal. In the conclusion, I must say there are just a brief summary. Identification of the superficial and the deep layer, as I mentioned into the start, is very deep layer of the fascia tonsillis is very rate limiting. Once you are in wrong place, you will move on, and there will be a lot of bleeding, and then it would be very difficult because there are small vessels which it will keep on oozing, and it will it will be like you will, once you lost your space, you will be in a complete disaster. General dissection of the reticulus and the bogler space and lateral dissection for the placement of the mesh. Complete paratalization of the cord structures again for the prevention of the recurrence. Placement of the larger mesh of 10 into 15 size, and the minimal fixation unless it is required. Thank you so much. And I would like to invite all of you for the Elsa 2021. We are in the middle of preparation. Thank you so much. Hand it over to Dr. Sujit and Mackie.
Oh, excellent talk, Sajid. May we remind our participants, if you have any questions for our speakers, please post them in the Q&A box, and we will see if we will have time to answer this live, or our speakers can answer you directly at the Q&A. So may I give the floor now to Professor Hiroshi?
Okay. Thank you. I want to share my slide. Can you watch my slide?
Yes, Professor.
Okay. Okay. Thank you for introduction, Sujit Mackey. Thank you, David, for giving me an opportunity to describe my TAPP procedure. Good evening, everyone. My name is Dr. Hirukawa from Tachikawa General Hospital in Niigata, Japan. And today's my topic is TAPP as a Nippon experience. There is one major concept about the structure of the abdominal wall that many Japanese surgeons have in common. That is the symmetrical structure of the abdominal wall described by anatomist Professor Tatsuo Sato in 1980s. The abdominal wall fascia is arranged symmetrically around the muscular layer like this slide. But some of the names are different from the name listed in a foreign literature. At the inguinal region, these structures are complex. Between the muscular layer and the peritoneum, there is investing fascia just behind the muscular layer, attenuated posterior rectus cyst, transversalis fascia, membranous layer of extraperitoneal fascia, and areolar layer. Here is inferior epigastric vessels, and here is cord component surrounded by spermatic cysts. Dissection layer is different between lateral side and medial side. In TEP, first enter between rectus abdominis muscle and posterior rectus cyst and break through the membrane, proceed to lateral side and reach to the front in front of the peritoneum. On the other hand, in TAPP, it may be first enter between the transversalis fascia and membranous layer of the extraperitoneal fascia and proceed to lateral and reach to the peritoneum. But I'm not sure it is confusing. This video shows TAPP for male direct inguinal hernia. The peritoneum was dissected 4 centimeters above the internal inguinal ring using electrocautery. And the lateral part, extraperitoneal space, was dissected along the peritoneum. This thin fatty tissue on the peritoneum will be an areolar layer of extraperitoneal fascia. On the other hand, on the medial side, The dissection is performed along the transversalis fascia closer to the abdominal wall rather than the lateral side. And you can see the fatty tissue on the abdominal wall side and the bladder side are each surrounded by a thin membrane. And pubic bone should be recognized as a landmark here. And this yellow fat, look at the capillary lens. This fat belongs to the abdominal wall side and dissected. And there is thin membranous structure over the direct hernia. This is probably the transversalis fascia. Dissecting the fascia, there is Suruzac. And it is Suruzac. According to this finding, Suruzac is not transversalis fascia. It may be an extension of the transversus abdominis fascia. Dissect enough to below the pubic bone. Next, once again, back to the lateral side, dissect the extraperitoneal space along the peritoneum and proceed toward the internal inguinal ring. And this structure may be so-called peritoneal loop. The lateral side was dissected along the peritoneum. Lateral side dissected along the peritoneum, and the medial side was dissected along the transversalis fascia. A thin membranous structure remains between the lateral and medial side. And it is important to recognize that the dissected layer are different on the lateral side and medial side. Dissect this membrane, it was integrated into the connective tissue around the external iliac vessels. And you can see the membranous structure disappeared. On the medial side of the vas deferens, there is another firm membrane, and it will be membranous layer of extraperitoneal fascia. I'm not sure that these are same structure or different, and it must be clarified future. The boundary between the lateral and medial layer is probably the inferior epigastric vessels. Connecting these layers create large space, insert large meshes, key concept of laparoscopic inguinal hernia repair. Next video is male indirect inguinal hernia. The hernia sac can be pulled out through the peritoneal cavity. And the peritoneum was inside 4 cm separate from the inguinal ring. In the lateral side, dissection was proceeded along the peritoneum. In the medial side, dissection was proceeded along the transversalis fascia, but this case there is some membranous structure. And you can see the hernia sac and the cord structure encapsulated in a certain membrane. And this membrane will be spermatic cyst described by Artery. By dissecting this membrane, separated between the hernia sac and cord structure, adequate tension to the tissue and short activation of the electrocautery, the tissue will be separated spontaneously. Tissue is separated spontaneously like this. The knack for effective use of electrocautery is to apply adequate tension, watch the boundary of the fatty tissue, and pay attention to the direction of the capillary, and use cut mode, low voltage mode. And can you see the capillary running curved on the fatty tissue? Dissect the tissue along the capillary by electrocautery like this, and separate the boundary of the adipose tissue. By this procedure, no bleeding and white and dry operation can be performed. And membranous layer is preserved on the parietal side and also in the inguinal canal. And this membranous structure surrounding the cord structure may be spermatic cyst described by Stopper. This procedure is, so to speak, for the central part of the inguinal region. In this case, inserted 15 by 10 centimeter Vastatex mesh and it was fixed by suture. The peritoneum was closed with 3/0 Polizov running suture. A stay suture was placed in the middle. It makes the suturing technique very easy. I always suture by like this one hand technique. And suturing the peritoneum is one of the most enjoyable part of this surgery. So I don't use barbed suture to close the peritoneum. And finally, anti-adhesion sheet is attached and the extra peritoneal space is aspirated like this. The most frequent recurrent site in laparoscopic inguinal hernia repair is lateral dorsal part. To widely dissect this area and insert the edge of the mesh into the space without folding is very mandatory. And I believe that this is the most important point to prevent recurrence. The mesh must be spread flat. Without folding. And you can see the mesh is spreading flat. And also the same for the flat mesh. This is Vastatex mesh. If you think the dissection was not enough, should not hesitate to dissect more. The key to avoid recurrence is to create large space and spread the large mesh flat without folding. That's all. Thank you for attention.
Thank you for that excellent demonstration, Professor Hiroshi.
Thank you.
So, for our participants, if you have any questions, just post them at the Q&A, and our speakers will answer them. So, I now bring to the floor our next presenter, George. George Yang is from Hong Kong.
Hello,
George, you have the
Hello.
floor.
Can you hear me clearly?
Yep.
Yep. Okay.
Yes.
So I will share my file. Sorry, just give me a minute. Okay, so can you see the video?
Yes. Go ahead.
Okay, so I'll start now. So today my topic is about laparoscopic management for strangulated hernia. And this is quite a complex topic actually. And the whole aim for doing laparoscopic surgery for all of you like laparoscopic surgeons are trying to decrease the laparotomy rate and also decrease the bowel resection rate. So we actually done a study showing in the laparoscopic arm there's a decrease in laparotomy rate and also bowel resection rate. And how does this come around? And then it's all due to the main factor is the time that we allow the strangulated bowel to recover. Okay, so I'll just go through this slide quickly before the videos, the rest of the videos. In open surgery, okay, so once we open up the hernia sac and free up the strangulated bowel, then most of the surgeon wait for 5 or 10 minutes. And then we have to decide whether we go for bowel resection or not. And then the repair of hernia is at the end of the surgery. But in laparoscopic group, after reduction of the hernia, strangulated hernia, then usually we proceeded to hernia repair first. And that gives us about 45 to even 1 hour for the bowel to recover. And actually a lot of bowel can recover during that time. So the number of bowel resection required is actually much decreased compared to the open group. And also, even if we need to reset the bowel, we can extend the subumbilical incision a little bit to about 3-4 centimeters to bring out the part of bowel and resect it. Because once we know that once we do the laparotomy, the risk of morbidity and mortality increases, and most of the major mortality and morbidities come from laparotomy itself. Okay, so the biggest hurdle in laparoscopic management of strangulated hernia is actually how can we reduce the strangulated hernia. Once we reduce the strangulated hernia, that's almost we are all relaxed. After the reduction of hernia, then you can decide on open repair or laparoscopic repair, and then come back to reassess the bowel to see whether we need the bowel resection. And these are all the videos on strangulated hernia reduction. This is a femoral hernia, you can see. Okay, sometimes the hernia is quite easy to be pulled back. Okay, and this is another hernia, strangulated femoral hernia. Okay, and during laparoscopy, we can also see clearly what sort of hernia and what type of strangulation it is. This is indirect inguinal hernia strangulated. Okay, so the essence in safe reduction of strangulated hernia is not by laparoscopic instrument pulling the hernia bowel back. It's actually by external compression. This is a richest hernia. So it's strangulated only part of the bowel, and the patient actually came in with intestinal obstruction. And you can see sometimes the herniated bowel do have adhesion to the herniated sac. So, and this is a lady with a strangulated omentum into the femoral hernia, and she also have an inguinal hernia. And the beauty of laparoscopy is that we can clearly identify which type of hernia it is and what is herniated, what is strangulated. And on the other side, she also have a femoral hernia and indirect inguinal hernia as well. And this lady, we go for TAPP. Okay, so we pull the herniated omentum back. So after the reduction, you can decide whether you go for laparoscopic repair or open repair for the hernia, and then you come back to deal with the strangulated omentum or bowel later on. So in here, we try to reduce the herniated sac of the femoral hernia. And in this video, we already opened up the preperitoneal space. And during this part, you have to be very careful not to injure the common external iliac vessels, obviously, because the external iliac vein is just next to the femoral hernia sac. Okay, and sometimes it's quite difficult to reduce the sac. You can see the sac now, completely reduced. And then you can decide that, what to do. Okay, laparoscopic repair in pelvic floor hernia actually has a lot of advantage compared to open repair. So femoral hernia and obturator hernia, I think we should do a laparoscopic repair. And this is another case, not inguinal hernia, but this is a similar. This is an incisional hernia of an elderly gentleman through previous appendectomy wound open. Okay, so we reduce the bowel mainly by external compression. This is my trainee. He said, let me do it. Then he really do an external compression and can reduce the bowel. And then there's a lot of momentum. There's also adhesion around the hernia. Or first, you can see the strangulated bowel at the back here, behind the omentum. And in a minute, we're going to look at it. So in laparoscopy, another advantage is because of the magnified view, we can actually look at the serosa of the bowel very clearly. And then you can assess the bowel more accurately. You can see whether there's any serosa injury from the strangulation and decide whether this bowel requires resection or not. Okay, and in this case, we decided not to resect the bowel, okay, because it showed quite a good response and recovery, and the serosa is still intact. And then we repair the serosal tear during the reduction. Okay, so if you give it enough time, I think about like 50 to 70% of the bowel can actually return to be safe without requirement of resection. Of course, like, you know, in the other spectrum, there's an obvious case that require resection. This is a huge hernia, intestinal obstruction again. So indirect inguinal hernia. So this is just an operative view, OR view as well. You can see, like, you know, we rely on external compression together with a laparoscopic guidance of where you should put your pressure on. And then you should grasp the bowel very carefully, not too hard. You can see, like, grasp it very, very lightly, although it seems to be very, like, you know, forceful. But you can see, try to grasp it very carefully, not to cause any serosal injury. And then, if you can't pull the bowel back, then try to use external compression. Okay, so these things can sometimes be quite tiring. Okay, by external compression, we can reduce the strangulated hernia. And this case, actually, although the bowel looked quite yucky at this stage, but after we repair the hernia, I even extend the umbilical incision to bring up this part and prepare for bowel resection. But then we decided not to because the bowel is actually quite okay. This is an elderly lady, 101 years old, with intestinal obstruction, strangulated femoral hernia for 2 days. Okay, and this case, you can see, like, you know, the bowel is definitely require resection. So we try to reduce the hernia by external compression again with internal guidance, grasping. We put a gauze in because anticipate that the bowel is most likely dead, and then we want to prevent any spillage. Okay, and you can see the gauze here, and then we try to reduce the bowel. Okay, by external compression mainly, and then internal slightly aid in pulling a little bit. Okay, and then you can see the bowel is returned, the bowel is here, and then this stuff actually came together with the bowel. We take some for culture in this case, but it's negative for any bacteria. The bowel is not very healthy, so we can't see exactly where the perforation is. And then there may be no perforation. We're not sure, but we're going for repair of the hernia first. So we plicate the whole segment of the bowel, and then go for the inguinal, go for the femoral hernia repair, and then come back for bowel resection like this. And then she recovered quite well. This is a strangulated omentum again. Okay, these are all case series, series of strangulated hernia. How we reduce it, and you can see there's adhesion. That's why the momentum will go back into the hernia sac. And this video just show you again how we reduce the bowel. You can see the strangulated hernia is here. So by doing it like laparoscopically, you can see in which direction you should push. Okay, and then you will notice there's a little pop. Okay, not now. This time you can see there's a little pop here. Okay, and the hernia is reduced. Okay. So we come to the part 2 of our my video. This is a case that I did several months ago. So this gentleman actually have known right inguinal hernia for some time, and then this mass started to be painful, and then he thought of wearing a hernia belt on top for 2 days, and then he come back in with vomiting, of course the intestinal obstruction, and he also have aspiration pneumonia as well. So you can see on the CT scan the stomach is full of substance. And the herniated bowel is down here below. So we put in right strip to empty her whole stomach, and then we go for emergency surgery. This is the strangulated bowel here. Okay, so this is intraop finding, laparoscopic finding. So there's a large piece of omentum herniate together with the small bowel. There's another piece of small bowel at the back. So we try to put use external compression. Fail. So we think of thinning down the omentum, may be able to aid the reduction of the hernia. Okay, still very difficult. Okay, a little bit coming back, but not much. So we keep on compressing. Okay, this is the small bowel. Again, we take down more omentum. Okay. All right, and then external compression again. And then things start to move, okay? And this is actually a direct inguinal hernia, not indirect. You can see the inferior epigastric vessel here. So this part of bowel, this one definitely require resection because you can see the cirrhosis very, very poor condition. So we put in a gauze and then we wrap the bowel around with the gauze. We'll try to not grab the injured bowel. You can see the serosal surface is very poor quality. So we use the gauze to wrap around the bowel to prevent any spillage if there's any. Okay, looks okay, still intact, but the quality is very poor, so definitely require resection. All right, then we go on for hernia repair. So we have to free all the adhesion first of the omentum. Okay, so when you do laparoscopic repair, you have to think whether you're going to do TAPP or TEP. Because if you're going to do a TEP, the working pot for peritoneal dissection, like have to be away from your TEP zone. Otherwise, you're going to have a gas leak. Okay, there's some adhesion around the omentum we take down as well. We're going to look at the bowel again before we go on to hernia repair, because just to make sure there's nothing leakage. If there's leaking, then we placate the bowel. Okay, at this point, well, one can decide whether to do open hernia mesh repair or tissue repair or laparoscopic hernia repair. I decided to go for laparoscopic repair because the risk of a mesh infection is exceedingly small, unless you have a very heavily contaminated field with a perforated bowel. And then after the hernia repair, we come back for reassessment of this part of the bowel. And this is what I'm talking about. So your peritoneal laparoscopic working pot has to be away from your TEP zone. Depends on whether you would like to put a pot like this or in the midline. So you have to decide what type of approach you're going to use, okay, to prevent any gas leak during the TEP. Okay, so we go into the preperitoneal space. We open up the lateral space, obviously. That's the easiest part. And this is the direct inguinal hernia. You can see the inferior epigastric vessel here. There's a lot of adhesion. So signify that this is a chronic hernia. He has a repeated episode of incarceration, must be. We try to reduce the direct inguinal sac. Okay, it's a chronic sac, so it's very easy to tear. Now, unfortunately, I tear it. So there's a holder. You can see we can look back into the peritoneal cavity again. So we need to sew this up. Okay, and then anyway, we go down into the pelvis. Okay, the external iliac vessel should be around here. So you can see actually in my repair TEP, I try not to use any energy device or cutting device unless it's necessary, like taking down the chronic adhesion here. But normally we try to avoid using any cutting because most of the plane can be separated. You can see now we're going back into the lateral space. That's an infesting fascia layer here. Most of the time, we go underneath this and then we will see the psoas muscle. Okay, so we open up this layer. So we prepare the lateral space for mesh placement. This is the lateral space. Okay, and after this, we go back to the medial part. This is the artery. Okay, we free the spermatic cord here. You can see the fast difference here. Because the mesh that we're going to use is Prioritex ADP2 mesh. They have a component that go behind the spermatic cord, and then another component overlapping in front of the spermatic cord. So in some country, like I think in Japan, they don't have this mesh. So this is not a sleep mesh by ourselves. This is a pre-made sleep mesh with have overlapping on the lateral side. This mesh is very good because the inferior parts actually will be pressed down by the spermatic cord itself. Because most of the laparoscopic hernia repair, the recurrence is by the inferior part of the mesh folding up. So using this mesh is almost impossible for the inferior part of the mesh to fold up. Okay, the inferior part of the mesh will be pressed down by the spermatic cord itself. Okay, so we come back to look at the bowel, and then you can see the bowel quality, and then we decided for bowel resection, joining the bowel here, and the patient was discharged. So we use the extended umbilical wound for bowel resection, and then the other pop wounds are almost like invisible 4 months, 3 months after the repair. And these patients, they're successfully discharged after the surgery, even given that he has aspiration pneumonia at the time of surgery. So avoiding laparotomy alone will greatly help the patients. Okay, so this is the end of my talk. Thank you.
Thank you, George, for that excellent demonstration. I think you have a question at the Q&A. Just answer it. And we'll proceed with our next presentation. Our next lecturer is Professor Sujit. I now give you the floor.
Thanks, thanks, Mickey. Okay, let me share the screen. Yeah. Can you see my screen?
Yep. Yes.
Okay, perfect. Yeah, so I'll be showing a couple of videos about endolaparoscopic approach for large inguinal scrotal hernia or large groin hernia. So this is a 96-year-old gentleman. He's otherwise quite well, quite active guy. And this is what he had. Yeah, so part of the small bowel was inside the hernia sac. Yeah, I think I will skip some of the early parts so we can preserve some time. So dissection, as according to how Sajid mentioned, so it's important in this large hernia that you create adequate space, and otherwise you may have to open the sac to reduce the contents in some cases under vision. But fortunately, the entire hernia, I managed to reduce it once the patient was under general anesthesia. So dissection of the sac. So we ligate the indirect sac. Yeah, and then we divide the hernia sac. It's important in this large sac. It's important to achieve a good hemostasis. Otherwise, the distal sac may bleed. So, and for the technique that I'm going to show you, it's important that we keep part of the distal sac so that we can do a TEP plus technique for this kind of cases. then palatalization of the peritoneum. So I'm using this bipolar energy device from Urbit. It's called Bisect. Makes it quite easier and makes the surgery faster. As you can see how big the distal sac is. So if we don't do anything, most of these patients, a seroma is guaranteed actually. So what we are trying to do here is we are inverting, we are pulling back on the distal sac, and we are putting some sutures to obliterate the dead space. So it's very important that in this indirect hernia, that the sutures are not placed inferiorly, because that's where your core structures are, and also infralaterally in this region where your all the nerves, cutaneous nerves are going in. And also need to make sure that the defect or the defect is not under tension after the repair, because it's against our principle. So basically pulling back on the hernia sac and then plicating it or imbricating it and then suturing it into the posterior wall. And I use ProGrip in this particular case. It's a 15 by 15 centimeter ProGrip mesh. Yeah, so that's immediate post-op after the surgery. So let's look at one more video. And in this case, this was both direct and indirect hernia. So dissection, not really different from what all the previous speakers talked to you about. But in this particular case, I had to, I felt that there was some contents inside the sac, and I couldn't completely reduce, so I opened up the sac and then reduced the contents under vision, and then ligated the sac. And then again, I did a TP plus repair. The TP plus repair we described for direct hernia, but in our center, we started performing it for inguinal hernia as well, and we found it quite effective in preventing seroma, as well as our long-term results showed is quite effective in preventing recurrence as well. So you can see how big the cavity is, and I left a bit of the distal sac to perform the TP plus for the inguinal. This patient also has, you can see the Hasselbalch triangle. He also has a defect there. So I'm just imbricating the distal hernia sac into the posterior wall, and I'm not suturing closer to any of the vital structures. So I'm using a barb suture. This is a non-absorber barb suture. So just imbricating the transversalis fascia of the direct hernia also into the repair or the imbrication of the transversalis fascia here. And all these patients actually they go home the same day in our center. Their pain control is quite adequate, and we use a special block As you can see, we inject in the pre-transversalis plane, just above the transversalis fascia, the soft tissue. We just inject the local anesthetic, and we found it is very effective in terms of the pain control, in addition to oral painkillers, and it reduces the intraoperative opioid usage. Okay, I think I'll show one more video about our TP plus for large direct hernia, M3s. So in a large direct hernia, it's very important that you get the transversalis fascia well away from where your core structures travel. So we need to grab it medially so that we don't suture near the core structures at all, and without creating much, undue tension. So here we are doing the same thing. We are just imbricating the transversalis fascia. Rather than trying to close the defect, we are just filling the gaps by retracting the transversalis fascia, or the so-called pseudosac. So I have really not like approximated the fascial edges. All I've done is just indicated the lax transversalis fascia. Then the rest of this is quite standard. I'll show one more video of femoral hernia. This is a patient who had a large femoral hernia with some incarcerated momentum, which we managed to reduce it intra-op. I'll fast forward this part a bit. So this is a reduction of the hernia contents. You can see the femoral hernia defect. So I had to divide a bit of the lacuna ligament to release it. So after that, just pushing back the contents. So if this was bowel stuck inside the hernia site, you can always open up the peritoneum, have a look inside, and then you can use an envelope to close it, or you can do a suture closure. Yeah, then the rest of it is actually quite standard paralyzation of the peritoneum. Yeah, so I'll just show this part, how we did the TP plus technique for this particular hernia. From outside, it was quite a big sac, but because this is a femoral defect and the neck was quite narrow, so creating adequate space to put the mesh. You can see part of the defect. So it's very important that you don't grab anything laterally here, because laterally what you have is the iliac vessels or the femoral vessels. So same thing again, imbrication of the transversalis fascia, or the so-called pseudosac. And here I'm suturing it to the lacuna as well as part of the Coopers. So in this large groin hernia, we felt that This technique actually can prevent seroma, and none of these patients actually had any seroma. And in long-term follow-up, their recurrence was actually quite good. None of them had recurrence as well. Yeah, maybe a bit technically challenging sometimes because you may have to suture with single hand sometimes. Yeah, but for large groin hernia, so this helps quite a bit. Okay, happy to answer any questions. I think I'm done here, so I'll stop sharing soon. Yeah, and that's it.
Thank you, Sujit.
Thank you.
Our next presenter is, of course, well known to all of us. I now give the floor to Professor David Lamanto, who will talk on recurrent hernias. David?
Thank you, Maki. Thank you to being with us together with all the other speakers. Let me share my screen. I think you got my screen, right?
Yes.
Okay, so my task today is to talk about recurrence hernia, inguinal hernia, how to treat it, and what is also the change in panorama. Very few slides, then we'll show some video. As we know, everybody believes that recurrence never happened. Unfortunately, it's happened. And if you look at some population-based study, they probably reflect recurrence quite high. We are talking about 10, 12%. If you look, of course, a randomized trial for a center of excellence is much below, like 1 to 2%. But probably we need to think that the recurrence rate about hernia is about 10%. If we are talking about re-recurrence rate after failed primary repair, maybe also up to 15%. Why hernia recur? I think there are some factors related to the patient because sometimes anatomically difficulty of collagen disorder may favor smoking, may favor recurrence. But most of the time, I think probably is surgeon related because experience count, approach, technique, type of mesh also is important. Sometimes we're enthusiastic about new technology. We use some technology that are not really up to date and validated. Why the hernia recur, or why a repair fail? Today, most of the repair are mostly mesh related, use a mesh. And usually when we do a Liechtenstein, an anterior repair or patch and plug, anything, usually most of the time, because we don't close properly the tail of the mesh and we don't overlap the medial defect, the pubic tubercle, at least a couple of centimeters. If we use a mesh that serves as self-gripping, for example, or sutureless, in which one stitches is only on the pubis bone, mostly because if they have direct hernia, the mesh is lift up and the hernia will recur. For posterior repair, that it can be either a Kugel open repair or TEP, laparoscopic repair, most of the time is a rolling of the mesh. That is probably due to an incorrect placement, incomplete dissection of the myopectineal orifice, and mostly on the lower part. We have guidelines that tell us what to do in case of a recurrent hernia, but they simply go through an algorithm that means after anterior repair, we go posteriorly. After posterior repair, we go anteriorly. That is obvious because we always go on the place that is so-called virgin. And this is what's happened, for example, in this case, usually is a simple, I have the command. So this is how the hernia repair. Let's move on. When you have a previous anterior repair, usually technically to do a TP, it doesn't differ much more from an anterior, from a primary repair. Only in some cases, like in this case, you can see the suture On top here, we're anchoring the mesh, we're anchoring the peritoneum or the preperitoneal fat. So the dissection may be a bit more complicated and complex, and we need to be extra carefully. But as Sujit say, and that's why one of the reasons why we start to do a TP plus, we notice that most of the time, like in this case or other case, the recurrence is mostly for large direct hernia. If you look at the indirect hernia recurrence for normal size, L1, L2 is about 1 to 2%. But if we look at medial side direct hernia that are larger than 3-4 centimeters, you can see the stitches here on the internal ring, very deep. There is a bit of a mistake of technique, as you say, because it shouldn't be so deep. The mesh is so dangerous because you have nerves, you have a iliac vessel, and so on. Anyway, so most of the time, the recurrence for large direct hernia. That's why we start to do a so-called TP plus and close down the direct hernia defect. Also in open, we kind of placate the transversalis to reduce the defect. So we start to do practically the same. And the large hernia, of course, are at higher risk. So for a previous anterior repair, I think nothing much, almost same as the direct hernia. You can see in this case also, the same case as before, a direct, indirect defect. In this case, the dissections proceed by isolating the sac from the spermatic cord, and then sometimes the retraction can be difficult because of the previous mesh. Then we proceed as a normal standard procedure using a 10x15 mesh. So the issue that today is there is a major trend, and we see much more recurrence because many more people start to do laparoscopic repair. The early stage of the learning curve is a bit more difficult. Maybe they already have a previous anterior repair. So the recurrent case that we try to get are much more complicated. So it is very important to understand the failure of the hernia. Why the hernia repair? Sometimes I don't agree that we need to do a repair because anterior we need to do posterior, posterior, anterior. No, I think we should understand why, what is the reason of the hernia repair. And this is we have done, for example, in 22 cases of our series in 5 years, we analyzed why the hernia recur. We saw that, for example, after posterior repair, this one, the mesh was too high in most of the case. So the dissection didn't go down to the retroperitoneal space as should be. Or in some of the cases, the mesh was too lateral, so the medial dissection was not completed. In 2 cases where the mesh was migrated because of the large direct hernia, only in few cases we can say is patient factor or mesh factor in which the mesh utilized was a microporous mesh, so high density polypropylene create the excessive shrinkage. Can be due to the mesh, can be due to the patient reaction to the mesh as a foreign body. So understand this reason, we may drive you to provide a better repair for the second or the third case, because as what we do, for example, let me stop the sharing. I show you a video. Yeah, interesting video. Sorry, yeah, we shared my VLC. You can see now the video. Hello?
Yes,
Yes,
Professor.
Prof, yes, Prof, we can see.
Okay, perfect. So a video that is run in virtual reality is edited. You can see I can move the video, and wonderful. You can see the movement, the position of the mesh. It's a patient that was referred to me for a recurrent hernia, and also I discovered a concomitant Spigelian hernia. You can see all the myopectineal orifice and the epithelium is all spoiled. You can see the inferior pigastric vessel here, the direct recurrent here. It's not the proper indirect one. You can see it's a Spigelian hernia. A very unlucky patient in which the previous surgeon did the TAPP was not very accurate. But it's interesting to see that the patient was a little bit chubby, and we don't find many more addition. We went behind the mesh, and you can see this is the Spigelian hernia. The indirect was okay. As Suji showed, in most of our case, we used to use a bipolar scissors as a bisect. It's from Herbe. We need to thank them because they are our supporter and sponsor in this event together with the Olympus. I think the company, we are very grateful when they can really support educational events and allow us to organize such a nice webinar. So this is a bipolar dissector, and we can see how the hernia is Spigelian, very rare in this case. So the patient was a bit unlucky to go to recurrence, but he was complaining also for a lateral bulge that in the repair 2 months before was never discovered. So experience also is also another factor. So in this case, you can see, if I zoom in, see a different way of providing education. You can see the hernia here. You can see the position is on the right side, and you can, on the right side of the patient, the movement. We scroll a bit more, and then the recurrence on the pubis bone on the anterior recurrence here. We are doing an extended ETP in this case because we want to also overlap above the arcuate line. So we have the recurrent here and the indirect hernia here. So we go back to the other presentation. It's here. Okay. And so one other video. You see, most of the time I prefer to do a TAPP, and more than all of you know that I have a TP guy does. Most of the time in recurrent, I prefer to do TAPP because I have a chance to better understand the reason why the hernia recurs. It's the only time that when I like the patient a little bit fatty, because the fat will be able to do a better dissection. I always start from the dissection from the side in which there is not much adhesion. And in this case, you can see the mesh is attached. I start always from the so-called virgin. If I see that the mesh is too high, I go on the lateral side, and then I go towards the medial side. Like in these cases, I approach, in this case, it was a large indirect hernia. We approach from the lateral side to the medial side. And of course, the last one will be the lower part of the mesh, especially the lower part in which the iliac vessels are more dangerous. You can see in this case a beautiful diagnostic lab. You can see how the mesh is very higher up. So what we use in this case too, the recurrence, we can just go across the lower edge of the mesh. We don't need to remove the mesh overall, everything, and we dissect lower down. That's why the recurrence happened. So by dissecting the lower part, we can replace another mesh on top of it. The small recurrence on the left side and another bigger recurrence on the right side. So we see the approach. We do a TAPP as usual. It's very important that you always keep yourself on the safer side. on the safer side, and then you do a dissection. Go always where there's no mesh, and consider that, of course, we don't go between the mesh and the peritoneum, but we always go behind the mesh. We bring the mesh down, and we go just along the mesh surface. Of course, the lateral point of view is safe, but when you go towards the midline, you must understand that there is always the epigastric. We sacrifice the epigastric, yes, but you must be careful that you may encounter the epigastric further down for the dissection. So you bring it down. Sometimes we put a mesh across. You always look at the iliac vessel, the vas deferens you can see in this situation. You can see the spermatic vessel here. So you must be very careful in avoid any danger. It's not a surgery that for everybody. Require a bit of atenolol before the surgery to avoid tachycardia and get scared, because if you create damage, I think it's quite important. So consent also wise must be important. As in this case, George showed you, I use a splitted mesh because it give me a better anchorage to the cord, and also sometimes we cannot go too much lower down because there is already another mesh lower down in this case, so it's not worth to go too low. Another small case, and then we have completed, is another patient also. They have already a bilateral 2 times repair, 2019, 2012, 3 times. So it is important to understand why it recurs. Why possible the 3 surgeons make so much mistake? Yeah, large direct hernia. That's why we start to do TP plus. If we close this defect, we have a better position of the mesh, and we have less chance of recurrence. Of course, it's a surgery that is a bit bloody because a lot of adhesion and a lot of attachment. And but with the patient, with the right instrumentation like a bisect, so it is possible to carry on. If we do open, that probably is the easier choice. I'm sure they may be able to recur again because this defect will be still there and open up. But slowly, we will be able to conduce a good dissection. The mesh in this case is higher up. Of course, in this case, you need to be careful of the bladder on the midline, catheter always, because surgery may last a bit longer. So and then you slowly proceed with the dissection. As I show you on the lateral side, because there's no adhesion, no mesh, it's easier to create an initial flap. Then you slowly move towards the midline, and you can see a meshoma here. The mesh is all quartered, and the mesh goes right inside the hernia defect, the large hernia defect. See the mesh is here all here with the sac attached. So we just go across. We don't cut any structure, anything that we don't recognize. We are very super careful because I told you danger can be opening of the bladder, injury the iliac vessel. Of course, in this case too, we always close the defect because otherwise we end up with another recurrence. This patient already have 3 bilateral repairs, so 6 surgery already. So we don't want to get another few. And we use a non-absorbable suture. And then in this case, because the flap was not mobile, we do a kind of trans-abdominal partially extraperitoneal. We use a mesh that is coated with anti-adhesive barrier. We suture on the lower side, and we fix with the stapler on the absorbable tack on the other side. So we do a kind of a tape procedure, trans-abdominal partially extraperitoneal. The huge lipoma we dissect. So what are the tics for recurrent hernia? For, as I say, for normal recurrent, simple recurrent after open repair, nothing much, a bit of a more addition because sometimes the surgeon went too deep. But you need to get as much information regarding previous repair as much you can. We need to get expertise, otherwise please refer to an expert or call an expert to help you. Have a very good camera system, high resolution camera system, because visualization is very important. Low threshold for conversion, because when you convert, you don't know what to do. Catheterize the patient, get a good consent, do a TAPP because diagnostically they give you much more information. Stay above the mesh, start where there is no mesh, create a space where the easier part it is, and tackle the hernia at last. You can ligate the inferior pigastric vessel if it's difficult, and there's no need to remove the previous mesh if it's well positioned, it's flat, if there is no mesh trauma. In this case, use fixation for the mesh, don't use any glue, use even metallic because you want to have zero recurrence. And so ultimate, you may consider an IPOM if you have a really multiple recurrence and you don't know what to do. Thank you. That's all on my side, Maki.
Thank you, David. Excellent demonstration and lecture. I now give the floor to our next lecturer, Professor Rajesh Kolyar from India. You have the floor, Rajesh.
Thank you, Mackie, and thank you, Sujit, and thank you, David. So I'll share my screen. Can you see my slides?
Yes, Rajesh, we can.
So now we come to the last presentation, and it is the most important because till now we have seen very good surgery performed by the excellent surgeons, and even very difficult surgery shown by David. You need to have very precise, but what the mind doesn't know, the eyes don't see. So we must know what all can go wrong whenever we do any surgical procedure, whether it is simple or complex. And the aim of science is not to attain infinite wisdom, but it is to eliminate the potential of infinite errors. We have to develop systems and procedures, as well as make advances to minimize the errors which can happen during surgery. And all of us know that no surgeon is immune, and no case should be considered routine, because complication can occur in the simplest of a procedure. And believe me, complications cannot be entirely eliminated, but early recognition and intervention can greatly improve the outcomes. So it is very important to recognize the complication if it occurs and take corrective actions immediately to prevent the morbidity and mortality in cases in which you miss a complication. So inguinal hernia repair, we have TAPP repair, we have TEP repair. There are certain complications of accessing the peritoneum which are seen in TAPP only, and these complications are common to all procedures which we do laparoscopically. The bowel injury, whether by trocar or by various needle, incidence is very, very low. This is the colonic perforation. The important thing is to put another trocar, not remove the trocar which you have put it in the colon. Put another trocar, change your camera to the second trocar, remove the trocar which has gone into the bowel under vision so that you don't miss the injury. And secondly, there is no contamination around in the peritoneal cavity, and suture repair the injury which has occurred. The decision to proceed for hernia or not, it depends on the surgeon. In such a case, I'd prefer not to put a mesh intra-abdominally or pre-peritoneally. Either postpone the surgery for some other day, or you can do an anterior repair. The vascular injury is another thing. You can injure a vessel in the retroperitoneum if needle is little. You are too enthusiastic in putting in the needle. You must see, observe. You can perform the surgery, you can complete your surgery, and then come back and see. If there is no increase in the hematoma, then nothing needs to be done. Actually, you just need to leave it because it's a tiny varus needle injury. So it's better not to touch it. It usually settles down to itself. Port side hernia are, known entity as peritoneum is breached, and the incidence of port side hernia after peritoneoscopy is 0.74%. You can have port side hernia even from 5 millimeter port, but any port which is 10 millimeter or more should always be closed, suture closed. That is very, very important. There is no recommendation as far as closure of 5 millimeter port, although hernias can occur as the one you are watching. The patient is unfortunate in this case if he develops a port side hernia from a 5 millimeter port, but 10 millimeter port is definitely known, and we must close the 10 millimeter port with port closure suture passer needle. Another complication which can occur after TAPP is disruption of the peritoneum, sutured peritoneum. If not sutured well or it disrupts, then the bowel can get adherent to the mesh, leading on to migration of bowel behind the hernial flap, leading on to intestinal obstruction, and that will require another diagnostic laparoscopy, and you have to suture close the peritoneum well. During TEP, if you can have the peritoneal tear, especially if there are a lot of adhesions of the peritoneum to the cord structures. Now, it is important to suture close these defects if the tear is more than 5 millimeter or 1 centimeter, and you can easily suture close it without any significant problem. Or in some cases, you can even use a loop, like in this case, if the peritoneum is loose. This is a recurrent case where you can see the interior mesh, which is adherent to the peritoneum. Do a good mobilization of the peritoneum, separating the cord structures and the peritoneum completely from all around. These are adhesions to the previous mesh. And once you have done that, you can even put a loop to close this peritoneal rent once you mobilize the peritoneum well. But the important thing is that you must close the rents in the peritoneum when you are doing TEP repair, so that no bowel loop can come and get stuck to the mesh, which may get exposed if the tear is opened up in the peritoneal cavity. Inferior epigastric artery bleed is one of the things which occur usually in the cases which are recurrent cases, like in this case. And this artery, you can cauterize it, you can use the energy source, you can put clips, you can put sutures. Not a very important vessel, only thing is it troubles you sometimes. You can put, the important thing is that you have to tackle both the ends very well, because it has blood supply from both the sides. So you have to be careful in taking care of this vessel. Another bleed from the inferior epigastric artery. Usually it is the recurrent cases, the mesh gets adherent badly, and while separating the mesh, the it's important, or it's better to tackle this inferior epigastric artery before it bleeds. You can sacrifice it, as David said, that in most of such cases you will have to ultimately cut it. So it's better to preempt the bleeding, dissect the inferior epigastric artery, and take control of it before it goes out of control. Testicular vessel bleeding is very peculiar, and it is very interesting because if you injure the testicular vessel near the reflection of the peritoneum, the proximal part of the testicular vessels get retracted. Like in this case, you can see the peritoneum is pushed down, and this is the testicular vessel which inadvertently had got cut. The distal part you can cauterize, the proximal part has retracted behind the peritoneum. And as your scope is from the umbilicus, it is not possible to locate the cut end of the proximal part of the testicular vessel. The surgeon thought that the bleeding has stopped, and proceeded, but when you saw laterally, they are still bleeding from the testicular vessel. And the way to control it is that you change your telescope from the umbilical port to the suprapubic port, so that you can look from below up. So once you put your telescope in the suprapubic port and look up, you'll be able to see the cut end of the testicular vessel, which is retracted and bleeding. Only thing you need to do is you pick it up and cauterize it properly, because it is very important to take control of the bleeding. And that's the way to manage bleeding from the testicular vessel which has got retracted. We know about the vasculature over the Cooper's ligament, and I don't know why, but it has been named as the corona mortis. The reason for that is because any bleeding from this area could be disastrous. And this is, you can see the multiple veins from iliac, external iliac to internal iliac, and dilated obturator, aberrant obturator. You have to keep it in mind that any vasculature injury in this area could be disastrous. So you have to be very, very careful to prevent any injury in this area. This was a patient of TEP who had fall in hemoglobin from 12 to 8, 4-gram fall, and he had a fainting attack. So we decided to rescope him after 24 hours. And you can see a large hematoma in the preperitoneal space. So this time we went through the abdominal cavity, opened up the peritoneum, and you can see so much of clots. Usually in most of such cases, the bleeding is usually stopped by the time you go in because of the pressure and contained hematoma. In this case, there was small ooze from the pubic bone. Probably it was a tack which injured one of the veins of the Cooper's ligament. Some energy device and some flow seal was placed to take control of the bleeding. We decided to keep the mesh because there's no infection as such. It was completely evacuated, a drain was placed, and the peritoneum was closed, and patient did well. Bladder is in the area of vicinity of inguinal hernia repair. And in recurrent cases, this is another recurrent case where the bladder is adherent and the surgeon is trying to make space. Retrospectively, you can see that the bladder mucosa is visible and the muscles of the bladder are visible. But during surgery, the surgeon didn't realize this. and this can lead to hole in the bladder. In spite of bladder being decompressed, you will see a Foley's catheter there. So one has to be very, very careful in these cases. You have to repair the bladder as you would normally do. Keep a catheter in situ for at least 3 weeks. Close the bladder in 2 layers, and the bladder is, if the urine is sterile, you can still go ahead and with the repair of the hernia. This is another TAPP with lower abdominal scar, previous lower abdominal surgery. Probably the surgery was prostatectomy, and you see what is happening. It's the bladder which is being cut, because there is no plane in between. The bladder is badly stuck to the anterior abdominal wall. That is the correct plane, and then you have to take care of this injury in the same manner. Now, what we have found that once you in such cases, you inflate the bladder rather than decompressing the bladder. This way you can identify exactly where the bladder is, and then you can go into the correct plane and you can prevent injury to the bladder. And by inflating the bladder till the time you are dissecting, you can prevent injury to the bladder. And after the dissection is complete, then you can deflate the bladder before you put in the mesh and complete the repair. This was a patient who presented as obstructed hernia, and it got reduced on the table. In such cases, it is mandatory to do a diagnostic laparoscopy to make sure that the bowel which was obstructed is viable, and then you can proceed to do a hernia repair. But diagnostic laparoscopy in such cases is very, very important. And after doing diagnostic, we prefer to do a TEP repair because that is what we normally prefer to do. Large irreducible inguinal hernia after reduction, you have to be very careful when you ligate the sac. A bowel loop was caught into the ligation. It was realized in time. You open up the suture, and after completing the surgery, you must have a look inside to see that the bowel which was stuck is not really injured at all. So that is very, very important. So whenever there is a large hernia and you have to reduce, you must open up the sac, make sure that the contents are completely reduced before you ligate the sac. This is one of the important aspects of inguinal hernia surgery, where a patient presents with a sinus in the anterior abdominal wall, and because of the mesh infection. And these patients ultimately, if it's a superficial infection, you can do incision drainage. But if it's a mesh infection, then the only treatment is removal of mesh. And the ideal is to remove the mesh laparoscopically so that you don't disturb the anterior planes, because these patients will definitely require the hernia repair later. Whenever you remove the mesh, it is very important to remove all the fixation devices also. And if it's been a bilateral repair, because the two meshes usually overlap in the midline, it is important to remove both the meshes. Always test the pus for atypical mycobacterium, because that is one of the common causes of infection in these cases. Seroma we have already discussed. Thank you very much for patient listening. It is very important to understand that all these problems can occur so that we can try to prevent them. Thank you very much. I'll stop sharing.
Thank you, Rajesh. I give the floor back to Sujit. What's our
Yeah.
next step?
Yeah, thanks, Mackie. So I think Prof. Lamonto is going to share a link with you all to do the MCQ. So and we will have a discussion with the panelists, and you can do the MCQ even after we close the session and submit your forms. It's on a Google form format. Yeah, so there goes the link. So please start doing the MCQ, and then maybe we can start having some discussion with the panelists. So today, Dr. Rakesh Gupta from Nepal has joined us as a panelist. We also have Dr. Lee Kwan from
Vietnam.
Vietnam, and we also have Marilu from Philippines, and Marilu has helped us to compile the MCQs. Mackie, you want to ask any questions from our panelists today?
We have one more question at the Q&A. A question from Dino, Dr. Dino Vargas from the Philippines. Anyone in the panelists can answer it. The question is, 10 years post-TAPP, is it safe to do TEP for recurrence?
I think Dino. Hello, Dino. How are you? I hope everything okay. It's very safe to do TAPP even after 6 months, 3 months, 4 months after TEP. Of course, more you wait, more scar, but not so soon is even better. So if you have a recurrence, please wait at least 6 months, 1 year before you go in again. If you have a failure of TP, maybe it's easy to go on open repair if it's not a large direct hernia. I don't know what are the other experts.
No, I agree to that because what he says after 10 years, recurrence after 10 years. So after 10 years, there should be no problem. If you want to go, the better would be a TAPP because you can see the structures around. TAPP will give you more chance to look at the anatomy and the reason for recurrence, as David had shown in his presentation. And you'll be able to do a good job doing TAPP for the recurrence, even after 10 years.
I agree with that, with you. I prefer to use TAPP repair because for the recurrence cases, we must make correct diagnosis.
Yeah.
Where the hernia protruded, where the mesh is located. This information can easily achieve by TAPP repair.
There are, I think, no more questions in the Q&A. Any other questions that you want to pose, maybe from one speaker to another? Soon? Any questions you would like to ask?
No, thanks.
Don, you do mainly TEP or TAPP?
I do mainly TEP.
And for emergency repairs, do you also do endolap or?
Yeah, of course. I will try to do laparoscopic surgery rather than open. And most of the case, I will do TAPP. We want to
for
see.
For emergency, yeah.
For emergency, of course.
Yeah.
Except sometimes when you do the anesthesia, there is a spontaneous reduction of the hernia.
Yeah.
Then I can do TEP at the end of the surgery, and we just go in and see how good the bowel is. And it's also very safe to have the final look at all of the bowel inside the abdomen after TEP.
Yeah.
Sometimes you have a spontaneous reduction of the hernias when you do the anesthesia to the patient. It happens sometimes. Yeah.
Rakesh, how about you?
Yeah, I'm fine, Sujit. Very
Yeah.
good.
Oh, yeah. So do you also do endolap technique for emergency hernia?
Yeah, we do, but in this COVID era, we stopped doing the emergency laparoscopic surgery. But before COVID, we used to do the laparoscopic diagnostic lab in most of the groin hernia patient who are fit for general anesthesia. But definitely patient with the bowel strangulation, or if we feel the patient is having peritonitis, we don't intervene with the lab. In that that sort of the patient, we directly go with the open approach. But yes, in obstructed without any feature of peritonitis, we go with the lab.
Yeah, Mackie, you got any more questions to the panel?
Yeah. Maybe for Professor Hiroshi,
Okay.
your main approach is TAPP, right? So
Right, right.
when you see a strangulated bowel, do you do the same thing as George, or do you do delayed repair?
If the bowel is dropping into ischemia, I will perform. I don't perform intraperitoneal repair. If I adapt a laparoscopic surgery for emergency case, incarcerated case, I will reduction. I perform reduction and laparoscopically and repair from the anterior approach. I don't use intraperitoneal mesh in the emergency, especially the bowel will drop into the ischemic change.
So the anterior approach will be an Liechtenstein, I suppose.
Yes, that's right. Liechtenstein is the most easy procedure.
You see, the same thing. I would say that if there is any doubt of strangulation, or if you have to do resection anastomosis, like George showed one case in which he had to resect the bowel, which was not viable. I would prefer not to do a intraperitoneal placement of mesh in such cases because of chance of infection of the mesh. I'll prefer either not to repair the hernia in that sitting, or if hernia had to be repaired, it will be better to do it from the anterior aspect. Do Liechtenstein repair. That will be, I think it will be safer for the patient.
Yes, I
keeping
agree.
in mind the infection which can occur in the mesh, because somehow once the mesh gets infected, the morbidity to the patient increases significantly.
I think I agree, just agree. The most important thing is to save the patient life.
Absolutely.
And next is repair the inguinal hernia. So if the laparoscopic surgery, during the surgery, the patient sign is very bad, stop the surgery, and afterwards repair the inguinal hernia. Repair the inguinal hernia by Liechtenstein is not so difficult.
There's a question on the chat box. Basically, they say, I use a scope holder every time during TAPP. It is very good to stabilize the laparoscopic image, but is not good for resident education. What do the panelists think? So who wants to take this? Yeah. Anybody want to
Anybody?
answer?
Yeah,
we
I would like to say that the best way for the resident to learn laparoscopic hernia repair is to assist, hold the camera. Why so is I tell all my residents that you have to have a mental connection with the surgeon when you are showing camera. You have to almost do the procedure yourself in your mind when you are showing a camera, because camera is the eye of the surgeon. If you don't see correctly, you can't operate. So the camera person, your resident who is showing you the camera, he learns each and every case what you are doing, and that is the best way to get the training. And most of our residents, after assisting, when they are with us for 2 years, they assist almost 100 cases. And by the time they are about to leave, they do exactly what I do in TEP repair. They have learned every step of it, and they can reproduce. So I think for training, yes, a camera holder, will just stabilize the scope, but it will not. You can't train the camera holder. you for the training, you have to train the resident. So if you have residents, I think the residents will be a better choice, because it is our responsibility to pass on whatever we have learned during our surgical career, to pass it on to our next generation. So it's a very good learning tool if they assist us by holding the camera. That's what I think.
I have a question.
The perfect cameraman is the perfect future
Absolutely.
EP expert. Sorry, Maki, go ahead.
Yeah, Rajesh, I have a question. Since you presented the complications, we don't often see mesh infection in laparoscopic surgery. So I suppose in your center, you did sort of a review or investigation of all of these mesh infections. And what was the culprit? What was the main cause of this mesh infections in the laparoscopic repair?
You see, in our center, we have, in our series of laparoscopic hernia repairs, we have no infection at all, zero infection. But our sister concern, Max Hospital in Delhi only, they did few cases, and they have infection in 3 cases, one after another one. And I had to be part to investigate why such a infection and why in such a short time. And it was early infection, so there had to be some breach in the sterility during the surgical procedure. And we found out that the culprit was the Sidex. The list used to be long in that operation theater, and they had only 2 operation theater, and they had only 2 sets, and the hernia had to be done at 3rd or 4th in the list, and the scope was sterilized by putting it in the Sidex. Although all our instruments were autoclaved, but scope was the only instrument which was not autoclaved and put in the Sidex. And that was the culprit. So we have now insisted in all our sister hospitals also that every set, including the scope, has to be plasma sterilized before any laparoscopic surgery. That includes even gallbladder, because in that center they had one port infection after gallbladder surgery also. So it is not pardonable in today's era to have sterilization by Sidex in your operation theater. Now the Sidex has been totally removed from all the Max hospitals all over India. There's no Sidex in the operation theater. So everything has to be plasma sterilized or ETO autoclaved in laparoscopic OT. So that is one of the main culprit which can lead to problem. Because Sidex gives you just high quality disinfectant. It is not a sterilizing agent. So in laparoscopic hernia repair, where mesh is being used, we have to have 100% sterilized environment, because mesh is just like an implant. So sterility is the most important, and this sterile chain should not be broken to prevent infection.
Okay.
Excuse me, Maki. I
Yes.
want to ask to panelists how is the infection rate after laparoscopic inguinal hernia repair? I have no experience infection after laparoscopic repair. Laparoscopic repair have advantage in terms of infection. So panelists every panelist how about the rate of infection after laparoscopic surgery?
See, as I said, in our cases, we don't have any infection. It's almost zero.
Yeah, George.
Yeah, I think well, I'll go first. Okay, laparoscopic repair and the infection rate should be close to zero. Okay, only in very exceptional cases. So you have to also look at when did the infection occur. Okay, so if the infection occurred early after operation, it must be you related or the handling of the mesh or theater related. Okay, if the infection occurred like several years later, then there's some question whether the patient is immunosuppressed or anything like that. And we have one case of mesh infection, but this guy had repeated infection in other systems as well, osteomyelitis, cystitis, pyelonephritis. And he had a hernia repair about 5 years ago. Finally, he had a mesh infection. So we removed the mesh, and then he also come in 6 months later with some sort of infection, and then go into DIC and died. So this is very questionable. This is the only case we have infections. And even for the laparoscopic management for strangulated bowel, like all the bowel that I did, all the cases that I show you, they don't have any infections. Okay, so the argument is whether to use the mesh or not in strangulated bowel, like even in gangrenous bowel. The problem is, even if you go for anterior repair, you still use the mesh. Okay, so if you go for anterior repair, you're using a mesh, so why not go for laparoscopic repair? Okay, the thing is, for what we did is we try to go for different planes. So we do the laparoscopy, peritoneal laparoscopy. So everything happening in the peritoneum. Then when we do the hernia repair, go for TEP. So supposedly this is a different plane. But initially we did a series, in our series of cases we published. Yeah, so in our series of cases, we did take a culture from the peritoneal fluid. All of them come back negative. So the mesh infection rate should be very, very low, unless you have a grossly contaminated field. Then I would suggest we do a tissue repair. But the problem is most of the trainee doesn't even know how to do a tissue repair. If you ask them to do open repair, the only method they know is Liechtenstein. So they go for mesh repair. Okay, so yeah, I think for laparoscopic repair, the mesh infection rate should be very, very close to zero. Should be zero. The thing is, when you're handling the mesh, before you touch the mesh, you should actually have a non-touch technique. So you open the pack and then put the mesh, grasp the mesh with a grasper, and put it directly into the pot, rather than let the nurse handle the mesh and hand the mesh to you. So many people have touched the mesh. That's not a good practice. So the non-touch technique, and then change your gloves before you put the mesh in. That's all the things that you should be looking for.
Any other?
Mackie, you will have to excuse me. I have some other commitment. If I can have the permission to leave.
Yeah.
Thanks, Rajesh.
Thank you, Rajesh.
Thanks so much for joining us.
Thank you.
I have a question to George. The technique that you showed is you did a diagnostic laparoscopy. and then you put a separate port for your TEP, right?
Yes.
But
If we're going to do a TEP, then have to be separate port.
yeah, and then how about the instruments? You use a different set?
No. But we clean them. We do clean the scope and the scope glasswork. But initially, I thought of this initially 15 years ago when I was still back in Laparoscopic hospital. When we first do the triangular hernia, we use a different set of instrument and even different scope. But since we take the culture, things like that is all negative, and then no case of gut infection, then yeah, we use the same instrument. But then yeah, it was okay.
Okay.
And the most important thing is you leave the bowel resection to the end.
Yeah.
So yeah, I mean you did the mesh repair, handling the mesh, and then you do the bowel resection right at the end. So it's supposed to be less contamination.
Yeah. How about the other panelists regarding your experience in infection? As questioned by Professor Hiroshi, have you encountered in your practice?
In my series, I have no infection, but I have some infection from other hospital. So one is because of repeated or multiple aspiration because of seroma early after TEP hernia repair. And after 4 or 5 times, there is really an abscess of the pre-peritoneal space that I have to drain by open surgery. Another interesting case is the patient after 2 or 3 times of reopen, we find that the patient have tuberculosis at the site of infection. This is weird, but really we don't understand why there is a tuberculosis over there. And after treatment of tuberculosis, everything is settled. Everything is good. So that is our experience on mesh infection.
Rakesh?
Yeah, we don't have mesh infection, but like in the emergency setting, if we do the bowel resection, then in those kind of patients, we don't put a mesh. We do simple prolene repair from the anterior, what we call simple darning technique, just a simple prolene, and we suture this conjoint tendon with the inguinal ligament. I mean, it's a tension-free kind of the thing. But as Dr. Rajesh mentioned, one of his slide, Mycobacterium tuberculosis, the atypical Mycobacterium tuberculosis is very common in our region. I mean, in Nepal. So this chronic port site infection is very common. What we call the Mycobacterium chiloni is one of the main culprit at the port site. And in one of the conferences in the Asia Pacific Hernia Society, somebody has presented a paper from India regarding the 35 case series of this chronic discharge from the TB and Tapp port site. So they sent the culture. The culture was most of the time it came a typical Mycobacterium chiloni, and sometimes it need definitely most of the time it can be managed with the antitubercular drug, and in few cases it need a complete excision of that port site. Chronic sinus tract excision is also needed, but we don't have any kind of mesh.
I must say also on our side, we don't have a mesh infection after laparoscopic repair. We have a few referrals from after IPOM for ventral hernia, mostly using micro porous mesh like a gore. And of course, we have quite a number of mesh infection after open repair. But mostly coming from Papua, Indonesia, Bangladesh, Myanmar. I remember the patient. Local patient, very, very, very seldom. India, yeah. Right, Sujit?
Yes, well, I think our own series, the cases that we have done, I think it's zero for the
Zero
last.
recurrence.
Yeah.
Let me share with you a fantastic result of the poll poll that we are doing this time. We are using a Google form. It's a fantastic tool, and we can have it online and live. We can release the result after that about the score. We can see. Can you see, right?
Yeah.
Can you see the country representative? We have a good number from Indonesia, from Philippines. The poll is ongoing. We have 44 people reply. And then also the position of the people. It's very good that we have a lot, almost 70% of fellow and junior. That is the target of our webinar. And also these are the answer, the question by one. And we will share the results later on. And also automatically we will have a release of certification for the one who passed the 70% results. That's all I want to just share with you. We will leave the poll open for another couple of hours. For all the participants, you have a link. Take your time, and because I'm sure we are going to conclude the webinar soon.
Yeah, Prof, there's one more question. So in a patient with gangrenous appendicitis and previous history of inguinal hernia, can both be done in one setting, and is it recommended? Sajid, do you want to answer?
I think if you are doing a TAPP, it's better not to do inguinal hernia repair at that setting. But for TEP repair, you can titrate your, equilibrate. You can go with the gangrenous appendix, you remove it, and then by the end of the procedure, you can start with all new instrument to go with the TEP repair. But I haven't experienced such case, but I did cholecystectomy like this with you and back in Pakistan as well. So I did both in one setting, doing a cholecystectomy, and then by the end of the procedure, did inguinal hernia repair with TEP approach. But gangrenous appendix, I think Prof. Lumanto, you can answer that. I haven't experienced the case.
Yeah, I mean, priority is the emergency. So your hernia is not an emergency, then just do it in a later stage, I guess, which is the correct thing to do. So yeah. One more question: is there any relation with port site infection with port site hernia? Tun, you want to answer, or Rakesh, anyone? Yeah.
Well, I can answer. If there's any infection of the surgical wound, there's always increased risk in hernia development. Whether it's a port site infection, open wound infection, that's the one of the main factor.
Yeah, right.
And also regarding the previous question, like whether you should combine the two operations, just to remind you that from hernia essential training, we should not combine the two operations.
Yeah. Exactly. Should see what's the emergency. Your hernia has been there before. And the patient coming in for gangrenous appendicitis, what would you go to go and touch the hernia? Anything else from Mackie, your side? If not, I think,
except you see gangrenous appendicitis in strangulated hernia. I think we could do.
Yeah.
We should do.
Yeah, that's right. Oh, just like to give my comments as well to Professor Roche's question. We haven't seen actually in our center any infections after laparoscopic groin hernia repair, but we've had referrals of there's one weird particular case wherein we saw an infected inguinal area after a TEP was done, but the TEP was done way like 5-6 years before, and I decided to approach this anteriorly. And when I opened up, the cause of the infection is the clips, the packer rather, and when we cultured it, it's also TB. So TB seems to be
Quite a common
infecting,
issue.
yes.
Quite a
So
common issue.
it's TB as
Yeah.
well. And you can actually see that the mesh was not infected. It was the tacker sites who had small sinuses where the mycobacterium grew. So we had to remove all of those metal tacks that were infected
Oh, quite
and then treat the patient.
quite interesting. Quite
Yeah.
interesting. Unique.
Any more comments from anyone else? If not, maybe we can conclude. It's around 8:30 Singapore time here. Prof. Hiroshi, you have any last words?
No,
No,
thank you.
Okay, so if that's the case, so I think thank you everybody for joining us. Thank you for the speakers and the panelists, as well as Marilu also here. She has set up his MCQ. Thanks to all the sponsors, Urbe as well as Olympus, and thanks for the attendees. And you can submit the MCQ through the online form, yeah, and then we will sort out the certification later on. Thanks so much. Yeah, Prof, over to you for any last words.
no, thank you very much. Thank you, Hiroshi. Thank you, Maki. Toon, Sajid, George, Rakesh, to be with us. Also, Rajesh left. I think it was quite fruitful. We have a good attendance, about 140 people between Facebook and here. So it's quite okay. You can see the age is our target, the junior and a junior consultant and a fellow resident. So that's all. I think we can invite all of them for the coming energy, surgical
Yeah.
energy workshop will be on the 5th of August. We will circulate on Elsa app all the information. Please, for all the participants, download the Elsa app, join the website to get all the information.
All right.
Thank
Goodbye.
you. Bye-bye.
Okay, bye-bye.
Bye-bye, George.
Thank you.
Bye,
Bye.
Sajid.
Thank
Bye,
you.
Prof.
Bye, Hiroshi.
Thank you,
Bye.
David. Thank you,
Bye.
David. Thank you.
Bye-bye, Hiroshi.
Thank you, Sujit.
Bye, Matthew.
Thank you.
Thank you.
Thank you.
Thank you,
Bye.
everyone.
Bye-bye.
Bye, Sujit.
Bye.
Bye. Sure.
Bye, Hiroshi. Bye.
Thank you, Georgie. Bye.
Bye, Tapp. Bye, Rakesh.